Alright. Is this good? Alright. Karan, is this about everyone? Is this everyone? Alright guys, we might get started. So, my name's Gavin, and I'm going to be doing your cancer and heme lectures. I'm one of the second years, if you don't already know me. So, what we're going to be talking about today, so introduction to cancer, effects of cancer, the molecular basis, so genetics and stuff like that, and also examples of different types of cancers that you need to know about. Can I get some quiet, please? Thank you. And then in haematology, so we're going to be talking about hematopoiesis and hemostasis. Are you guys fairly confident on cancer and hematology stuff, or is it a hard area? It's all right? Yeah, okay, cool. You probably won't get that many cancer and heme like questions in the exam. So if you don't have time to study for it, that's cool. Just flip through the slides. You'll be okay. All right, we'll get started. So what is cancer? Cancer is abnormal and uncontrolled division of cells which invade and destroy surrounding tissue. It develops from normal cells, usually because of genetic errors, and the process is called transformation. We call the development of we have the development of normal cancer cells, which is just transformation, and then we have the development of tumors, which is a solid mass, so as opposed to just single individual cancer cells developing, and we call that tumorigenesis. Tumor also means swelling, so we generally associate cancer with like swelling, and like people who have cancer, like swelling in the lymph nodes, there's that kind of association as well. All right. So there's two ways cancer occurs. So it either occurs through mutations in the cell cycle, so you get unregulated growth because there's no stopping mechanisms, or cancer cells are able to avoid apoptosis, so they become immortalized. They can occur in normal cells, or they can occur in stem cells. Stem cells is generally much more harmful because you're getting like a whole populations of cells affected. And they lose their ability to carry out specialized functions. So if you get, say, cancer in your hematopoietic stem cells, you're going to get loss of function like white blood cells, red blood cells, things like that, which is very, very bad. All right, features of cancer cells. So this is pretty important, maybe the most important part of the lecture. And I think it's important to know why each of these happens. So first one, enlarged nucleus. Because they are undergoing mitosis so often, there's this accumulation of DNA. So you get a lot of DNA built up in the nucleus, and it just becomes physically larger. They become immature. So because they're developing so fast, so rapidly, they're not developing their specialized features, which means they're not able to carry out their specialized functions. And so we call them immature in that sense. No contact inhibition. So normal cells will stop dividing once they come into contact with each other, once there's enough cells, like once there's too many cells in a certain area. Cancer cells do not do this. So they will continue to grow, even if there's a lot of, there's a high population of cells in a certain region. And we see that when cancer cells, they start to grow, like normal cells will grow in a monolayer, and cancer cells will sort of grow above that, if that makes sense. No anchorage dependence. So normal cells, they need to stay either attached usually to a basal lamina, which sits underneath your epithelium, or some sort of surface. Cancer cells do not. They can move around and they can still survive. Reduced requirements for growth, external growth factors. So they produce their own growth factors, which enables them to grow. and then changes to cytoskeleton. Because cancer cells are moving around, because they metastasize to other parts of the body, the cytoskeleton needs to be a bit more mobile. It needs to allow them to sort of deform a bit more. And so that's what we see in cancer cells. More features, so they're resistant to inhibitory growth signals. I think that's kind of a given if they're producing their own growth signals. Accumulated genetic errors and chromosomal aberrations. So that's happening because, again, they're undergoing mitosis so much, there's less time to repair and more likelihood for errors to occur. And then active telomerase. So you guys all know about telomeres. I'm sure someone has told you time and time again. But telomeres basically are an indicator of the age of the cell. So telomerase is what replenishes telomeres. And in cancer cells, you have activation of telomerase. So in essence, you're getting lengthening of the telomeres. And then the phagocytic cells in your body who are going to be telling cancer, like normal cells, to undergo apoptosis, they'll see those longer telomeres and be like, oh no, this cancer cell's fine. We don't need to kill it, and hence it evades apoptosis. And finally, it mimics self-antigens, self-molecules, so it's not recognized by the immune system as a foreign kind of thing and doesn't kill it. All right, this is just a nice table summarizing it. I took it from your lectures because I'm not going to make a table like this. You can go through this in your own time, I think. It's everything I've just said. All right, development of cancer. So you can either have inherited cancer or you can have acquired somatic cancer. Inherited cancers, as I said, it's inherited, it's genetic. You get one gene. You can only inherit one cancer gene from your parents. If you inherit two, then your baby is going to die and you don't see that. That's why you only really inherit one gene. Somatic, it's the development of cancer due to mutagens, so viruses, smoking, radiation, stuff like that. And then we require at least 4 to 6 mutations in a single gene to cause cancer. Sometimes they'll say 5. If it says 5 on your exam, go with 5 as well. It's within 4 to 6. And then mutations occur in 2 to 3 types of genes. We'll go through this later. But oncogenes, tumor suppressor genes, and mismatch repair genes. Okay. Acquired cause of somatic cancer. This isn't really too important. Just be aware that these can cause cancer. Don't remember them. So radiation causes damage to DNA. That will cause gene mutations. Viruses can cause damage to DNA because they are... Question?
Sorry, I just had a question about when you're saying 4 to 6 genes.
Yeah.
Does that mean 4 to 6 mutations in one particular oncogene or?
Yes.
Okay, so it has to be the one gene, not multiple mutations throughout different genes. It has to be in one gene.
Yes.
Okay.
Yes. Does anyone have any more questions about that, or was that fine? Also, like, if you have any questions, just feel free to like put your hand up or something. Actually, I should probably repeat the question so people on recording can hear. All right, we'll keep going. So acquired causes, so viruses, they incorporate themselves into the genome, and so we'll get cancer from that. Cervical cancer. That's probably an important one to remember. That's caused by HPV, I think. HPV, human papillomavirus. They can also cause expression of certain proteins. Bacteria, so the big one for bacteria is gastric cancer caused by Helicobacter pylori. It's that Aussie guy who like swallowed the bacteria. I'm pretty sure you guys have heard of it sometime in your lives. And then alcohol, diet, age, smoking, and then chemicals. All right, oncogenes. So in order to understand oncogenes, we need to know what proto-oncogenes are. So proto-oncogenes are just responsible for healthy cell division, healthy cell growth, and mutations in proto-oncogenes will result in the formation of oncogenes. So oncogenes will cause inappropriate cell division and inappropriate cell growth, and hence that will cause cancer. In order to have an oncogenic sort of cancer, we follow this one-hit hypothesis. So for every gene, we have 2 alleles. We only require for oncogenes one allele to be mutated, and that's because oncogenes are gain-of-function mutations. So they express a sort of dominant kind of mutation, and that's why one allele is generally sufficient in order to cause cancer with reference to oncogenes. So there are different ways in which we can have transformation of oncogenes. So we can either have deletion or mutation in the coding sequence. So we get this hyperactive protein. We get overactive protein caused by gene amplifications. We have multiple of those genes, so we're getting multiple proteins, multiple of the same protein. Or we can have chromosomal rearrangement. So either we're pretty much just getting a hyperactive protein being created because two genes are being put next to each other. And that's either because the new protein being created itself is hyperactive, or one of the genes is produced a lot, and so by association, that proto-oncogene will now be produced in great amounts. Does that make sense? Yeah. All right, tumor suppressor genes. So these control cell cycle checkpoints, and they're the cancer-preventing kind of genes. They regulate cell growth, kind of stop it from getting out of control. They're also involved in transcription, DNA repair, apoptosis, and you can either have inherited mutations or acquired mutations. So if we think about oncogenes, if one is enough to cause cancer, then we don't get inherited oncogenic mutations. The baby will just be dead before it happens. Whereas in tumor suppressor genes, we can have one inherited allele and we can still like be functioning, we can still look normal and stuff until we get that second mutation. Yeah? And so that's why we say it's a two-hit hypothesis. We need mutations in both alleles of the same gene to cause cancer. It's also considered loss of function mutation because we're losing that function of preventing cancer, that kind of stuff. All right, this is just a nice diagram. So the first A is where you don't have an inherited gene mutation. So you have to, both of those alleles have to mutate in order to cause cancer. And then B, one of those alleles is already mutated. You got that from your parents. Very unfortunate. And then the second allele mutates, and that's when you get cancer. So by extension, it would make sense that people who have inherited cancer genes, inherited mutations in their tumor suppressor genes, will likely develop cancer earlier. That's just statistical. All right, mismatch repair genes. This is the unimportant one of the three. So they're involved in DNA repair during S phase. They also follow this two-hit hypothesis that you need two mutations to cause cancer. Sorry, mutations in two alleles to cause cancer, and it also a loss of function mutation. All right, any questions about anything I've said? Nope, okay, metastasis. So metastasis is all about invasion and spread of cancer from one area of the body to another area of the body. So I'll just go through the stages of metastasis. I think there's a diagram in the next one which will be a bit more self-explanatory. But first you have to go at the development of cancer in one area. So it needs to evolve, maybe form a tumor, maybe not, but it needs to like develop, colonize one area of the body. Next, it secretes proteolytic enzymes. So those break through the basal lamella, what sits underneath the epithelium, or endothelium, I think, actually, in your like tissues and stuff. Do you guys know what basal lamina is? Yeah, cool. Okay, so that sits underneath the endothelium. So it needs enzymes to degrade that so it can move through it and into the bloodstream. And then it extravasates into the bloodstream and lymph, one or the other. And then it follows the blood and lymph patterns, the flow patterns. That is an exam question, just remember that. It follows blood and lymph patterns, cancer metastasis. So it'll follow the blood and lymph patterns, flow to wherever it goes, and then it'll get to these capillaries somewhere in the body, who knows where. And because capillaries are really, really small, it's likely that the cancer cells will adhere to the cell walls, the blood vessel walls in those capillaries, and it will extravasate. It will adhere, move out of the cell walls. Blood vessels, fuck. And so that's your primary metastasis. The second part is all about secondary colonization. So this is in order for it to actually develop a tumor in the other part of the body which it has metastasized to. So the important part for it to do that, the important thing you need to know, is that it needs angiogenesis. So it needs the formation of new blood vessels to sort of support that cancer growth in that secondary site. And the way it does that, it secretes this thing called VEGF, vascular endothelial growth factor. It's all in the name, growth of vascular endothelium, growth of blood vessels. It secretes that, and then blood vessels will kind of grow and reach the cancer cells, and it'll be able to sort of develop a new tumor site. And that's because it's getting oxygen, and it's getting nutrients, and it's getting a method of waste removal. And until cancer cells can successfully start this angiogenic process and successfully get a blood supply, it won't really generate a tumor. And that's why cancer cells can stay dormant for a long time. So they can just sit and sit and sit until they successfully undergo angiogenesis or whatever, maybe like 10 years later. And that's why people get like the surprise of their life. Yeah. Yeah. Actually, that was a pretty good pun. All right, so this is a nice picture. So you can see here, yeah, mouse is working. So cancer cell moves off the original primary tumor, so it doesn't have anchorage dependence. It'll evade, it'll intravasate, circulate, reach a capillary, extravasate, and then move to that site and colonize with the side thing of angiogenesis being required. All right, types of cancers, not that important, but I'll just say it for niceness sake. So 85% of cancers are epithelial cancers, like skin cancer, things like that. And then you can have sarcomas. So sarcomas are cancer of the bone, muscle, or blood vessels. Lymphomas, cancer of lymphoid tissues, and then leukemia, cancer of leukocytes or white blood cells. It's important to note the difference between lymphoid and leukocytes, but we'll talk about that later. All right, types of tumors. So benign tumors, they're not that bad because they tend not to metastasize because they've got this sort of fibrous capsule surrounding it. So they're unlikely to like extravasate, they're unlikely to go anywhere. And they generally resemble the normal tissue. So they haven't really lost their specialized function yet. And they don't really cause problems unless they're in a confined space where they will impinge or impede upon like nerves or like other tissue functions. So the good example of that is the brain, where there's limited space. If you have a tumor in the brain, it will impede other brain function. And in comparison to that, we have malignant tumors. So there's no fibrous capsule around this, so they're more likely to metastasize and invade other tissues, and that's why they're more problematic. And then a nice table comparing benign and malignant tumors. You can go through that in your own time. How much time? What are we on? All right, histological section. So it's good to be able to identify the differences between normal, malignant, and benign cells. I never really had a great way of doing this, but you can see like normal cells, they look pretty, like I just think of like happy and angry cells. Normal looks pretty happy, benign is starting to look a bit like weird. High benign is like, I don't know what this is messed up. And then malignant is like some alien, I don't know, like that's just messed up. That's the best way to think of it. If you want, you can go by like nucleus size, so you can see like all these little dots. Those black dots are the nucleus. And so there'll be an increase in nucleus size. There'll be more deformities in like cell shape. But honestly, I think going by like the happy, angry is like way easier. All right, moving on. Local effects of tumors. So they can displace normal tissue. Obviously, if you have cancer cells growing in a certain compartment or a certain organ, they will displace normal tissue. And that can deteriorate tissue function. So if you have like in the brain, they'll be unable to perform their functions if they're being like compressed upon or something like that, or they are just losing their specialized functions. So a large proportion of that organ will be cancer cells, and hence they'll be immature, and hence they'll be unable to perform that function. So there's two ways it can happen. They can block vessels, lumen, so like capillaries, arteries, vein, lymphatics, because if they're metastasizing, they can stimulate they can cause cachexia, sorry. So that's weight loss. So in cancer patients, you'll generally see people losing weight, like 5 kilos in a month or something like that. It's because they have a high metabolic requirement. So a lot of the nutrients are going towards those cancer cells as opposed to all the other cells in the body. And so you'll get like this breakdown of like muscle and fat and stuff like that. And they can also secrete hormones to other cells and does other stuff. Don't really need to know it. All right, inheritance. So why do cancers show familial aggregation? So one, they generally, if you're living in the same family, you'll have like the same exposure to, I don't know, like UV if you all go to the beach at the same time on the same days or something, or like if you're all living in a house with asbestos, then maybe you'll get cancer. Or genetic predisposition. So it's just genetic. So in your genes, you're inheriting alleles. Yeah. Most cancers are spontaneous. So 90% of cancers are acquired, 10% are inherited. That's a fact you should remember. Penetrance. So percentage of individuals with the affected gene who develop cancer. So if I was a mum with breast cancer and I was giving my child a breast cancer gene, if they develop cancer, the chance that they develop cancer will be the penetrance rate. So in breast cancer, it's about 40 to 70%, but it varies between different cancers. And there are some that you need to know, but again, we'll go through that later. Okay, indications that a cancer is inherited. Most of these are pretty like common sensey. So if you have several relatives with the same cancer, it's probably genetic. If you have two relatives with the same rare cancer, it's probably genetic. Early age onset, it's more likely that you've had an inherited allele cancer. And so you probably have an inherited cancer, bilateral cancer. So if it's happening on both sides, like of your like, I don't know, kidneys, or if it's happening on both sides of both your eyes or something, it's more likely that it will be inherited. If it was acquired, maybe it would probably affect one side more than the other. But inherited is generally bilateral. And then tumors in two different organs. So again, you've got this like inherited cancer, it's more likely that you'll develop cancer. Earlier, sorry, I forgot what I was saying. Terms you need to know, so penetrance, the proportion of people who develop the cancer if they have that genetic allele that they've inherited. Non-penetrance is just this idea that people who have the allele can not get the cancer still. Anticipation, so people will develop, you're anticipating that people who have like inherited alleles will develop cancer early. And then phenocopy. So if you look in a genetic pedigree and you see like all these, like there's a pattern of inherited cancer, and then maybe there's one which isn't actually inherited, but you think it's inherited, it will appear as a phenocopy. It will appear that it's inherited, but it's really due to environmental factors. All right, P53. So it's an important protein. It's involved in arresting cell cycle. So it either stops the cell cycle to either allow DNA repair or allow the cell to undergo apoptosis. It's a tumor suppressor gene, and so in cancer, it is generally affected, causing like unregulated cell growth, et cetera, et cetera. And I think the important thing to know is that it's mutated in, it's mutated in 50% of cancers. It's the big like gene that is mutated, so that's why they put a lot of research into trying to fix P53, because if they think they fix it, then it will be like, people will get less cancer and stuff like that. All right, examples. So we're just going to go through a couple examples of different types of cancers that you should know. First one is colon cancer. So this bottom picture is what normal colon should look like. This top picture is what cancer colon looks like. And we call this familial adenomatous polyposis, caused by a mutation in the APC gene. I think the important fact to note is that it's almost 100% penetrance. So if you have this, you're pretty likely, if you have the gene for it, you're pretty likely to develop cancer. Generally, you'll get polyps developing as benign polyps, and they will, if you find them early enough, you can remove them and there won't be a problem. But they will eventually become malignant, and that's when they need to be removed. And I guess the classic like sign or symptom is malabsorption of nutrients. All right, breast cancer. So there are two types of breast cancers. You can have either a BRCA1 mutation on 17q or long arm of 17q, chromosome 17. Or you can have BRCA2 mutation on the long arm of chromosome 13. Not too important, but just a fact I thought you might want to know. Individuals with breast cancer predisposed to ovarian cancer, 40 to 70% penetrance rate. Again, remember that penetrance rate. it'll probably be an option in MCQ, and you'll have to like pick it or not pick it. So it's good to know it. And then indications of inherited breast cancer. So again, as I said before, it's bilateral, early age. If you have male breast cancer, which is really, really unlikely, then it's probably inherited. And concurrent ovarian cancer will probably mean it's also inherited. Retinoblastoma, another type of cancer in the eye. It's kind of like a creepy thing. And again, it's a tumor suppressor gene. So you can either have hereditary or sporadic retinoblastoma. Hereditary, it'll develop younger age, it'll develop bilaterally, and you'll have a mutation in in one allele of every cell in your body. Sporadic retinoblastoma, it will occur later in life. It will occur in only one eye, most likely, and the mutation will only be in some cells because it is acquired. And then the final example, chronic myeloid leukemia. So I think, do you guys spend like an active learning on this, talking about like how it works and stuff, or not? Yes? No? Was it in a lecture? Okay, I'll talk about it then. So it's basically, this is your hyperactive fusion protein being created. So it's created from the fusion of chromosome 22 with chromosome 9 and the production of this Philadelphia chromosome, which is 22q minus. So I think it's like shortened 22q or something. I can't remember. And you get this overactive fusion protein being produced, which activates your tyrosine kinase receptors. So tyrosine kinase receptors are basically involved in breaking apart ATP and releasing energy. So obviously that will be involved with reactions, activating reactions pretty much. So they'll be involved in activating like cell proliferation, cell differentiation, mitosis, stuff like that. And so if you get overactivation of these tyrosine kinase receptors, you get a release of ATP, excessive release of ATP, and then uncontrolled production of cells. And this typically affects myeloid cells. So these are your like white blood cells pretty much. And you'll get this like production of immature white blood cells, and you'll have this deficient kind of immune response. Because they're immature, they won't be able to respond adequately to an infection or whatever. Methods of treatment for this one, so you can either have inhibitors at the ATP binding site, so it's a competitive inhibitor. You can have anti-tyrosine kinase antibodies, so basically an inhibitor, but it's an antibody. Or you can have anti-angiogenic, so you block that VEGF, you stop the tumor colonization kind of thing. All right, hemopoiesis. Oh, it's hemopoiesis, okay. Cool. Do you guys want a 2-minute break or not? Just rushed into it. Cool. So we have 3 layers of blood. I'm just going to do it anyway. We have 3 layers of blood. So 45% of it is red blood cells. We have less than 1%, which is your leukocytes and platelets. We call that our Buffy code, so it's white. And then plasma, which is just everything else. That's 55%. Don't really need to know the numbers, but like if you have time, learn it. And then important requirements for red blood cell development. I would say this is pretty important, not just for exams, but in the long run. Iron, vitamin B12, and folic acid are all super critical for hemopoiesis. All right, hemopoiesis. Is it hematopoiesis or hemopoiesis? Okay, whatever. So HSC differentiation, it's driven by cytokines, interleukins, and CSF. These are just molecules, chemical regulators that are involved, whatever, you don't really need to know it. Maturation primarily occurs in bone marrow. So in the like medullary cavity, in that inside red bone marrow, very heart of the bone. And so we get this differentiation. So we start off with differentiation into myeloid and lymphoid cells. Lymphoid cells will become your plasma cells, lymphocytes. Myeloid cells become platelets, red blood cells, or some other kinds of white blood cells. And we have this differentiation between the kinds of white blood cells we're producing. So granulocytes, they'll have granules in them, as the name suggests. Agranulocytes will not have granules in them. And agranulocytes come from your lymphoblasts. Granulocytes will come from your myeloblasts. Just remember it. All right, erythrocyte formation. So we get HSCs, we get our common myeloid progenitor, a bunch of steps you don't need to know about, and erythrocytes. The main sort of mediator in this is erythropoietin, and that's produced in your kidneys. All right, red blood cells, they have no nucleus. So prior to being released into the bloodstream, their nucleus is removed from them, removed from the cell. If red blood cell production is occurring too fast, then you might get like red blood cells which do have a nucleus in them. They circulate for approximately 120 days, good fact to remember. And in order to maintain like adequate oxygen supply, you have to have an equal amount of sort of red blood cell production with red blood cell loss. That's just a homeostatic kind of requirement you should have. All right, other facts: biconcave, anucleate, no nucleus, no organelles. Major function: transport of gas, O2 and CO2. They're transporting O2 to tissue. They are transporting CO2 away from the tissue to the lungs to be expelled. They have a flexible shape so they can get through capillaries, very deformable, no mitochondria. So that's really important. They can't undergo like your, citric acid cycle or your electron transport chain, whatever's happening in that mitochondria. So that's why they only pretty much undergo anaerobic glycolysis to get all their energy, or they will go through this other pathway called the hexose monophosphate pathway, which you don't really need to know about, but just be aware that it exists. All right, hemoglobin. So this is an important part of red blood cells. There's 4 polypeptides in a hemoglobin molecule, 2 alpha chains, 2 beta chains, and there's a heme group in each of these proteins. So for every polypeptide chain, there's 1 heme group. In every heme group, there is 1 iron molecule. Binding affinity, oxygen. So once you get 1 oxygen binding to a heme group, you'll get, the binding affinity of oxygen will increase. So it's more likely that more oxygen will come and bind to that. It's important to know about 2,3-DPG. Do you guys get that? She shows you like a graph or something. Like it goes like that or something. Some weird looking graph. Yeah, I have no, I wouldn't say bother learning it now. It's like a waste of time. But know what 2,3-DPG would do. So it basically increases the release of oxygen from hemoglobin at tissue sites. So if you have increased 2,3-DPG, you'll get increased oxygenation to your tissue, and hence you'll get decreased binding affinity, yeah? That makes sense just like as a logical sequence. And so if you have decreased 2,3-DPG, you get decreased release of oxygen, and hence increased binding affinity to the hemoglobin molecules. Does that make sense? Cool. I think that's the really only important fact. And just, it's also an intermediate in glycolysis, if whoever wants to know that. All right, iron. So iron is really important for oxygen transport. We need iron to transport our oxygen. Otherwise, that process is severely impaired. So we get about 10 to 20 milligrams of iron each day through our diet. We absorb about 1 to 2, so about 10%. And that iron will it'll go towards a variety of different processes. So 75% of it will go to erythropoiesis, so into your red blood cells. 10 to 20% stored in the liver and heart in ferritin. And then 5 to 15 goes to whoever knows. I have no idea. And this all occurs via transferrin. Transferrin will transfer the iron all around the body to either the bones to do hematopoiesis, or ferritin for storage, or whatever other processes. And you can also lose iron each day from desquamation. I think that's just like losing skin or something like that. Don't really need to know that. All right, iron. So again, as I said before, we're eating about 10 to 20 milligrams. We're absorbing 1 to 2 milligrams. And then Fe2 plus is absorbed more easily than Fe3 plus. That's meant to be a plus. Again, just a fact you need to know. Types of iron. So you can either have heme iron or non-heme iron. Heme iron is from myoglobin or hemoglobin, so animal sources, meats. Non-heme iron is from dark vegetables, so vegetarians. Vegetarians will derive their iron from non-heme sources. All right, moving on. So in terms of actually iron, vegetarians just generally need to eat more. They either need to take supplements, or they'll need to eat like huge amounts of dark vegetables, just because the concentration of like iron in like vegetables and stuff is much lower than in muscle, in like animal stuff. All right, degradation. So once your erythrocytes are being broken down, your hemoglobin has to go somewhere, yeah? So it will be divided into your heme and your globin. Globin will it'll be digested by proteases or whatever. Amino acids will be recycled in the body for other functions. And then we'll get the production of biliverdin and carbon monoxide or something, and iron from your heme. Iron can it will be recycled or will be lost through desquamation. And then your biliverdin will be converted to bilirubin, urobilinogen. You don't really need to know that. I would just say, remember that iron is being recycled throughout the body. All right, erythrocyte abnormalities. So you can either have abnormality in number or function. If we have anemia, we have low amounts of red blood cells or low hemoglobin levels. Polycythemia, poly meaning many, emia blood, many blood. I think psi is like cell or something. You have high levels of red blood cells. We can have deformities in like structure. So if they're not the right shape, then they won't have like great surface area for like gas diffusion at capillaries. We can have like improper antigens, so we get lysis or glutination, immune reactions, stuff happening like that. We can either have improper like defects in globin chains. That's where you get thalassemia. People don't have the right like alpha or beta chains, or we can have enzyme deficiencies. Leukocytosis, you don't really need to know much. Again, it's stimulated by interleukins, CSFs, and cytokines. So that's all over here on that side. All right, leukoabnormalities. So you can have leukopenia. So penia means kind of less. Leukocytosis, cytosis, or leukophilia, I think sometimes they're right, is an increase. So philia is like love of or something. So that's a good way to remember it. Eosinophilia, increase again in eosinophils. Neutrophilia, increase. And then abnormalities you can have. So you can have multiple nuclei, cytoplasmic inclusion. So stuff that isn't meant to be there pretty much, or nutritional deficiencies. So again, immature cells, improper cells being formed, they're not carrying out their proper function. Thrombopoiesis. So this is platelet production. It occurs by the release of sort of these fragments which sit in megakaryocytes. The key mediator to remember is thrombopoietin, so that's pretty easy to remember, thrombocytes, thrombopoietin. And again, you can have that as thrombocytopenia or thrombocytosis. Penia, low amounts of platelets, or cytosis, high amounts of platelets. Histology, it's one slide, it's just a picture. You might be asked to like identify different things, and honestly, I don't really have a great way of doing this. Platelets is easier because it's small. I think eosinophils and neutrophils are generally multinucleated, or they have multiple lobes in their nucleus. Don't quote me on that, but they generally look like that. Basophils, they are granulocytes, so they're filled with all these like highly filled with granulocytes. Monophytes and monocytes, they have like that single cell, large kind of nucleus, like macrophages, and erythrocytes just look like erythrocytes. All right, hemostasis. How are we going for time? Okay, pretty good. So this is all about coagulation, blood clotting, and dissolving of clots. Did anyone have any questions from that part of the lecture? No? Okay. All right, so what is hemostasis? So it's all about formation of a clot. So we want to block hemorrhaging, we want to stop bleeding, stop blood loss. It involves a variety of things. And once the endothelium has healed, that clot will be dissolved, and the cell will go back to normal. I mean, the tissue will go back to normal. What do we need to know about platelets? They're produced in bone marrow from, again, megakaryocytes. They are cytoplasmic fragments / small discoid particles, and the production is regulated by thrombopoietin. Coagulation factors, so they're circulating proteins involved in coagulation. They can either be enzymes or cofactors, so enzymes require activation, cofactors do not. They are the activating kind of things. Most of them are synthesized in the liver, and vitamin K, which this is important because I hadn't underlined it. So remember it. So vitamin K is important in the production of factors 2, 7, 9, and 10. The way to remember that is like TV channels. I think she probably tells you that. The good TV channels at least. All right. And they are involved in your secondary coagulation pathway. All right. These are the different coagulation factors. Don't remember them. I would say though, like it's helpful knowing what fibrinogen is and prothrombin is. If you had to remember any two, I would say remember those two. Sweet. All right, stages of hemostasis. So there are three main parts. We have vasoconstriction to begin with, formation of a primary platelet plug, and then the formation of a secondary fibrin clot. So your primary platelet plug is your temporary clot, and your secondary one is the more permanent one. All right, first step, vasoconstriction. So sympathetic pain receptors, they will cause vasoconstriction. Someone else will go through that. I'm sure your neurophys person told you about it. So that's all about limiting blood flow. So we want to limit blood flow, limit blood loss. That's why we sort of aim to reduce blood flow by causing vasoconstriction. Formation of the primary platelet plug. So the damaged endothelium will be exposed to the ECM if we have damage usually. And that will cause the release of thrombogenic factor. Thrombogenic factors. The most important thrombogenic factor which activates this whole sort of primary platelet plug formation is von Willebrand's factor. Without that, we struggle to get the coagulation in general. So lack of people who have a deficiency in that will struggle to clot. So this will activate it will cause platelet activation, recruit more platelets to that site, and cause the cross-linking of fibrinogen. So that's your factor 1, and that forms sort of like a temporary meshwork over your damaged endothelium, and that's your temporary blockage to hemorrhaging. After that, you'll get a coagulation cascade. So you can either have, I'll go through it on the next slide as well, an intrinsic pathway or an extrinsic pathway. So intrinsic pathway is caused by damage from within the tissue. So things like atherosclerosis, internal trauma. Extrinsic pathway, it's caused by damage from outside the tissue. So external trauma, like if someone just stabbed you or something like that. And then common pathways, you can see 10-2-1 are common to both of them. Yeah. All right, so I'll just talk about the common pathway because you don't really need to know about the actual steps in the extrinsic and intrinsic. So the common pathway will move to factor 2. So factor 2 will just cause the activation of factor 1. It will cleave fibrinogen into fibrin. Fibrin is soluble. Fibrin will then will be converted into, again, another meshwork over your original primary platelet plug. That will form your firm secondary hemostatic plug. That's the detail that you really need to know. Like those last two steps of it, factor 2 and factor 1. Are we cool with that? I'll explain it again on the next slide. So this is the picture you get. Remember the pathways, I think. So the way I remembered it is tissue factor is factor 3, and it's debatable about whether 7 or 3 comes first, but if she puts 7, go with 7 first. So go 7, 3, 10, 2, 1. 10, 2, 1 is common. Intrinsic pathway, it starts from 12 and just goes down. So we'll go 12, 11, it goes to 9 because we already know 10 is part of the common pathway. So we know we can just go to 9, and then we'll go to 10, which is that common pathway. Common pathway is 10, 2, 1. Intrinsic, 12, 11, 9, 10, 2, 1. Extrinsic, 7, 3, 10, 2, 1. Just remember those numbers. Like, I don't have a great way to remember it. All right. Moving on. Like, I think maybe a good way is just like repeating it to yourself and saying those numbers really, really fast so that it just becomes like a ingrained thing. All right, fibrinolysis. So what happens when we have healed our endothelium? We need to get rid of our platelet plug. We need to dissolve our clot. So that happens by this molecule called plasminogen. So plasminogen is converted into plasmin, which will then dissolve our fibrin clot. It will dissolve the cross-link bridges between your fibrin monomers, stuff like that, to dissolve it. So the activating cofactors which convert plasminogen into plasmin are TPA, UPA. Inhibiting factors are plasminogen activator inhibitor, or plasmin, you don't need to know that. and this is just a diagram which summarizes it. So plasminogen is converted to plasmin by TPA and UPA. Plasmin dissolves fibrin into fibrinogen degradation products or fibrin degradation products. And it can be inhibited either at the TPA or at the plasmin. Inhibitors aren't that important, but know that plasminogen is converted to plasmin, and then that converts fibrin into fibrinogen degradation products and fibrin degradation products. All right, these are the different products you can get. Fragment D is the end region of a fibrinogen molecule. Fibrin E is the middle region. Fragment X is DED, dead, X, dead. Fragment Y, DE, that's the other one pretty much. So if you remember fragment X is dead, then you can remember fragment Y is DE. And then D dimer is double D, DED. All right, tests. So generally you just do a full blood examination. You look at everything. They're pretty quick and easy to do, so that's why you just do them. If you have more concerns about clotting and platelet stuff, you'll do more tests. So prothrombin time will measure your extrinsic and common pathways. Activated partial thromboplastin time will do intrinsic and common, and thrombin time is just the common. I think the way I remembered was common. Thrombin is in both of the other ones, so that's why it's common. I can't remember that's a good way. That's good enough for me. You can guess the other two. It probably won't come up. And this is just a diagrammatic form of it. So this is your thrombin time. This is your prothrombin time. And this is your activated weight, partial thromboplastin time. Oh yeah, the way I remembered it. So intrinsic has a lot of factors. It's longer, so that's why the name is longer. Prothrombin time is like the less longer name, so that's why it's the extrinsic one, which is the shorter pathway. And then common pathway is just your thrombin time, because it's common in both of the words. All right, causes of hemostatic disorder. We are almost at the end. So we can have either disruption to primary hemostasis, so that formation of the temporary blood clot, or the formation of the secondary blood clot, that coagulation cascade. So that can either be to platelet abnormalities, blood vessel defects, congenital coagulation factor deficiencies, or acquired deficiencies. So that's caused by, like, if you're not eating enough vitamin K, your liver's not functioning because the liver produces a lot of our coagulation factors, or stuff like that. Not too important to know, but just make sure it makes sense to you. Thrombi and emboli differences. So thrombus is the initial mass that forms. It's attached to something, a certain part of the body. The emboli is the thing that breaks off and floats away into, like, I don't know, your lungs or some other capillary somewhere distant. Just know the difference. Causes of thrombosis. So Virchow's triad. So it can either be due to endothelial injury. These are the common causes of thrombosis. So endothelial injury, we damage the vessel wall. That's what we've been talking about for the past half an hour. I hope that makes sense to you. Abnormal blood flow. So either the blood is it's turbulent, so it will be hitting the wall more, causing more contact of coagulation factors with the wall, or it's static. So it's not moving, so the blood just sits there, so it's more likely to aggregate, agglutinate. Or abnormal coagulation. So you have altered coagulation factors, altered properties of your coagulation factors, which predispose you to hypercoagulability. That's probably genetic. All right, questions? Good job, we made it to the end, and we're early. All right, which of these factors is not synthesized from vitamin K? Just shout out the answer. What's the consensus? I made it Roman numeral, so it's harder. Are we happy with B? E? All right, yep, good job. B is the answer. Remember, factors 2, 7, 9, and 10. All right, which of the following statements are correct? What are we thinking? Ooh, we're all quiet now. Who wants to yell out the answer? Yeah, good job. Yeah. Any questions about that? No? So tumor suppressor genes are loss of function, oncogenic are gain of function, proto-oncogenes are the normal form, so oncogenes are the mutated form, and then single gene defects, we need multiple gene defects. All right, prothrombin time is a measure of what? What do we think? So remember the long one is the long pathway. The long pathway was what? Wait. Fuck. Did I not put the answer up? That's... No, I think that's right. Oh, fuck. Yeah, E is right too. Good job. I was testing you, of course. All right. Inherited cancer predisposition syndromes are what? Yeah, that's the answer. C? Yeah, C. Do you want me to go through that? No? Yes? Okay. So BRCA1 is 40 to 70% penetrant. Familial aggregation occurs in majority of cancers. Presence of tumor in two different organs is suggested in inherited cancer syndromes, or bilateral or things like that. They represent approximately 10% of cancers, and then single gene defects account for more than 10% of cancers. That's just not right. Like you need multiple gene defects, and it is 10% of cancers for genetic. Does that make sense? Sweet. Cancer is associated with E. Yeah, good job. So we need loss of function for mismatch repair. Chromosomal rearrangement, remember, was for proto-oncogenes, so that was your gain of function kind of mutations. Loss of function for tumor suppressor genes, gain of function for proto-oncogenes, and then E is correct. All right, which of the following blood components are derived from megakaryocytes? C, yes, thrombocytes. That's all right. Which of those is not necessary for metastases? What are we thinking? D, yes. So we do need angiogenesis to supply our new cancer secondary site metastases. We need cell motility to move through the endothelium. We need to secrete proteolytic enzymes to digest the extracellular matrix. We don't need a virus. Cancer is not really immune related generally. And we do need decreased adherence, so we need it to move. All right, which of these is uncharacteristic of malignant tumors? What are we thinking? D. Which of these is uncharacteristic? I think it's, yeah, A and D. Yep, my bad. D is also correct. Which of these is untrue about hereditary retinoblastoma? What do we think? A, B? Yep, C. So most do develop a tumor. Tumor is generally bilaterally. Mutations are required. So we don't need mutations in both alleles if we already have an inherited allele which is mutated. Yeah?
Doesn't that make the answer A quite vague in the way that it's explaining it? Because most people would compare the mutant RBG on tumor. It's not true because it's hypothesis. So one of them is to use lightning research, but it's not most. I don't know that you can say that most people who compare it themselves.
I think C is more correct than A.
I'm with you, but
Okay, that's it. Good luck. Any questions? No? Okay, yeah. Good job. If you have any questions, just feel free to message me or like email me or whatever. I'm down for whatever. I'm just under time. How do I? Should be fine. There's probably mistakes in there, but I don't care. It's no, it's all good. That was scary though, isn't it? Like quiz you.
Were you in the right place?
Yep.
Yeah, that's one. Thanks. What do I talk into? This one?
You can either use the mic, that's fine as well.
Okay, cool.
We're also live streaming, so if someone has any questions, I'll let you know.
Okay,
Yes?
cool. Do I have to wait for it to click over or just start now? Like, do I have to wait for it to be 1:30 or just?
They just like wait for a minute or so. I mean, if they're fine with it, just jump into it. I'm not like
Alright.
Are there any free slides? Which they use to
It's literally the same thing. Like.
Do you mind if I just upload it there?
Oh yeah.
So people could just download it.
I put it into maybe the wrong folder. I don't know.
Oh, okay, that's fine. I'll just have a look.
Is there gonna be a I was told that someone would. That's why I didn't put them in.
Because normally that hour lecture was way to that. Yes,
No, and
so they uploaded it and then it was recording for it. And they uploaded a really like really empty because I'm pretty sure I haven't watched the video. I think it goes through it in the video. So it's like really like what and then I'm seeing it talk about it in the video. So we haven't had a lecture like a lecture. Our lecture was and then our backup lecture was 6. Then we ended up having no lecture.
Have you not had a lecture for this?
No,
if you have, and have you had a look at the recording?
I haven't had a chance to look at every slide. The slides are like nothing because I assume that he goes into more detail in the recording.
Okay.
Yeah.
Generally with anti-cancer drugs, it wouldn't. You'd cover a bit more of it in second semester and second semester, second year mostly. The drug glossary would have a few anti-cancer
I've
drugs
got
on them.
there's a PDF. This has got everything on it.
Yeah.
So that'll have the cancer drugs too. But they won't examine you on stuff you never got taught. So
Yeah.
If you upload the recording of the then I assume that we actually that's why I'm wondering like
I'll go through it on using the PDF. I didn't make slides for it, but I'll go through it anyway.
And general gist is this is if you ever come across a question on the exam which hasn't been covered either because the lecturer didn't turn up, he was sick, or the content was different, he didn't get enough time, you'd let Akhil know, your academic rep, and he would have a meeting with the tutor after the exam and get all those questions removed. So it should be fine. If there is content missing, don't worry about that. If there is a video, have a look at it. It should not be too hard. And the PDF is well loaded. It's really, really good. And just generally, There aren't a lot, and most of them have pretty similar mechanisms. But no, you get maybe one question at the max.
So when you talk about anti-cancer, they also encompass like monoclonal, like just like drug specific.
There's one monoclonal antibody that you have to learn.
Yeah,
Okay.
and the question on that is going to be which of the following is used as a monoclonal, and you always have like MAB at the end,
Yeah. Okay.
which stands for monoclonal antibody.
Yeah.
So it's not going to be a hard question for these drugs.
They include therapy as well. Therapy like cancer therapy.
So like treatment algorithms and stuff. Like how would you treat them, or just?
I remember how immunology too. There was like.
Yeah. No. I know. Is that the tutorial you have like biochem and immuno?
No, it was like a one more take it outside of class. It was on a Wednesday on our free day.
Okay.
And it was like we have to learn about monoclonal, like talk about how it was. One of them was like the diagnosis. So one of them was monoclonal. That's obvious. The other one was for like diagnosis. So like using. So it was like using IgM instead of.
That's very niche stuff. It's not really examinable. It's to kind of help you understand the entire process a bit better.
Okay.
But if you're going to get a question on monoclonal antibodies, the maximum you could get was to identify one, and it should be pretty straightforward. Yep.
Gosh, mouse makers.
Oh. Wait till someone in the audience raise their hand.
Alright. Okay, guys, we'll start. Okay, hi, I'm Bella. There's my auth Kate, and you can send me a message on Facebook or email me if you have any questions later, but preferably ask me during today. Okay, so I'm going to go through Pharm, and the intention was the person who went through cancer with you was meant to do the anti-cancer drugs, which I've been informed didn't happen. So I'll go through the cancer drugs at the end. Okay, so what you need to learn, I would recommend learning them in this order. Hang on a sec. Okay, so neurotransmitters and receptors, that's sort of like neurophys, but if you don't know that, trying to learn the ANS drugs is going to be a nightmare. It won't work. That's what I tried to do last year. It doesn't work. So I'll go through the neurotransmitter stuff. There's some pharmacology principles, and then actually learn the drugs. The drugs themselves, like learning what drug does what, is not worth a whole lot of marks in the exam for how much work it takes. So don't stress over it too much. Focus more on the principles, things like that. There's also antivenoms I didn't cover, but it's in that PDF that I uploaded. It's all you need to know is like what happens if you get a snake bite, you know, immobilize the limb, that sort of stuff. It's really basic. Okay, here's the neurotransmitters. Is that readable? So what you need to know is that for all cases, acetylcholine is always the neurotransmitter, except at the NMJ for sympathetic nervous system. And you need to know at which sites there's nicotinic receptors versus where there's a muscarinic receptor. So the only place there's a muscarinic receptor is at the NMJ in a parasympathetic nerve. And then for the noradrenaline at the NMJ, it's just an adrenergic receptor. Does that make sense? Is that all good? You need to memorize that, otherwise this is not going to work. Okay, so pharmacodynamics. Pharmacodynamics is what the drug does to the body. So this is looking at absorption and distribution. So we're looking at, you know, it binds to a receptor, you get a signal transduction, and then you get an effect elicited. The drug receptor bond, it can be weak or transient, so something like an ionic or a hydrogen bond or a dispersion force. So the effect is going to be reversible because it can dock to the receptor but come out just as easily. Oh, sorry. Or we could have a more permanent covalent bond can be made, and then it's an irreversible bond. Agonists initiate signal transduction to produce the effect, whereas antagonists block the endogenous substance from binding to the receptor. So agonists increase the effect that the endogenous substance would have made, whereas antagonists oppose the effect of the endogenous substance. So here's a summary of the different kinds of agonists and antagonists you can have. So an agonist, think of it as the key fits the lock and it opens it. An antagonist, the key fits the lock and it doesn't open it. A partial agonist, the key fits the lock and half opens it. So it's sort of like you've got the same number of binding sites occupied as a full agonist, but it's producing a lesser magnitude of an effect, despite the fact that we've got the same number of drug particles. And an inverse agonist, the analogy doesn't work anymore. The key fits the lock and makes it more locked. So you're actually eliciting the opposite effect of the endogenous substance. Okay, so pharmacokinetics. This is what the body does to the drug. So we're mostly looking at metabolism and excretion. For absorption of drugs, all you need to know, it's like year 11 and 12 chem. So acids, you know, are proton donors, bases are proton acceptors. So with this little equation of like the generic acid dissociation, right? If we take an example of an acidic drug like penicillins, so penicillins are strong proton donors. So in a really acidic environment, on this equation, you're going to get a shift to the left, right? So you're going to have a lot of the penicillin is unionized. So an acidic environment, for example, is the stomach. So you swallow the penicillin, in the stomach it's acidic, there's a shift to the left, the penicillin's unionized, and only uncharged particles can diffuse across membranes. So that means that the penicillin in its unionized form can cross the membrane, whereas something that's very basic will have trouble crossing the membrane because it will be charged. And it's in equilibrium. So once you've absorbed the unionized drug, then the ionized component will shift to the left again, and you'll get, it's like does it in batches, if that makes sense. Is that good? Okay, distribution. So considering the solubility of the drug is really important. So fat-soluble drugs can accumulate in adipose tissue, and small fat-soluble drugs can cross the blood-brain barrier. This is important if you consider you've got two identical patients. They both say they both weigh the same amount. You've got two 70-kilo patients. One of them is 70 kilos of lean muscle mass, whereas the other one has got high body fat percentage. Then you give them both the same fat-soluble drug. The overweight patient is going to hoard a lot of that drug in the fat instead of, it's not going to be in the blood where it needs to be to act. So you'll need to give the patient with the higher body fat percentage a bigger dose of the drug. And likewise, the patient with the higher body fat percentage, because they've got this reservoir of the drug, it's going to take them longer to get rid of it all after you stop the treatment. Does that make sense? Yep, okay. Metabolism and excretion. I don't know whether it's worth learning which drugs are metabolized by the kidney and the liver. Last year, like PSP is always pushed for us to learn that, supposedly because you might get a patient with like kidney failure and you don't want to give the renally metabolized drug to the renal failure patient, but I don't know that that's fair game in first year. Know the principle behind metabolism. When we're metabolizing drugs, the idea is to make it more water soluble so that it can be peed out. Other modes of excretion are tears, sweat, milk, and stool. You want to know the ones that pass through milk because you don't want to give them to lactating women. They will ask about that. Okay, so bioavailability. This is the fraction of dose that reaches the systemic circulation as unchanged drug. By definition, an IV drug has 100% bioavailability because it's just going straight into the circulation. As opposed to the blue curve, which is oral, it's going to take a while to reach the circulation, and not all of it's going to get there. Some of it wasn't absorbed. It was just lost straight through the GIT. And our loss is still, it's going to be metabolized by either the liver or the kidney. Can someone tell me, why is that red line there curved rather than just a straight line down that way? Otherwise, I'm going to pick on someone. Yeah? What I mean is that this red curve does have like a bit of a scoop to it, slightly. And why does the red curve have a bit of a scoop to it at all? Wouldn't you expect it to be a straight line? Yeah? Yeah, good. Why? Okay, yep, you? Yeah, so about whether it's a constant rate of excretion versus the half-life sort of thing. Is that what you're getting at? Yeah, exactly. So in the red curve, we'd be going from, let's say in this chart, the half-life is 4 hours, right? So we started at t equals 0, we had 100 drug, right? And then after one half-life, after 4 hours, we've now got half the amount of drug. So now the drug we've got 50. And then after another half-life, after another 4 hours, we've gone down to 25. So that's a drug that's got like a mode of half-life excretion. The example they'll always use for constant rate of excretion is alcohol. So whether you've got 1 standard drink in you or 10, it's always 1 drink an hour going out. So that's when you'll get the straight line. Does that make sense? Okay, therapeutic window. So this is the difference between, so we've got minimum toxic concentration, so that's the lowest dose at which you start poisoning the person, and minimum effective concentration, which is the lowest dose at which you actually get some sort of therapeutic effect. So you ideally want a really wide therapeutic window because you're not going to be playing between, oh no, we don't have enough drug to actually treat the patient, and then now we've got too much and we're killing them. So the wider the therapeutic window, the safer it's going to be. You're not going to be, subtherapeutic, killing the patient, subtherapeutic. Does that make sense? And there's a thing called a loading dose. Have you learnt that this semester, or is that some two? Loading dose? Yes? No? Okay, never mind. Don't worry about it. Just know the therapeutic window, you want it to be big. Okay, so now to the actual drugs. Everyone's super keen to learn the actual drugs. It's worth very few marks. Still do it, but don't spend too much time on it. Okay, so for every drug there is, you need to know the indications for each drug, the mechanism of action, the mode of administration, mostly just for antibiotics, this is more important, contraindications and side effects. So rather than, I've avoided like delivering, I haven't put like a title, drug A, and then all these things because it's really cumbersome and that's just a matter of you flashcarding them. So I've set up what you need to study, and in that PDF, it's got it all anyway. So you just make flashcards out of it and memorize it. Okay, so these are the ones for the ANS. These are antibacterial drugs. The antibacterial drugs are really overwhelming because all you see, like before you start studying is that antibacterial drugs for a bacteria infection, and then depending on which one, you're like, oh no, which one do I pick? So it's important to learn which ones are for gram-positive versus gram-negative, and also their mode of administration is really important. So if you learn that a drug is intravenous only, you're probably going to not use it in a really common infection because that's not a convenient mode of administration. You'd rather use your oral stuff first, it's easier. And this sort of links into, you would have learnt the antimicrobial creed, mind me, which tells you that microbiology informs the therapy. So you got to know what bacteria the person's infected with before you start choosing a antibiotic. The indications should be evidence-based. You want the narrowest spectrum required. So different antibiotics will have a different spectrum of bacteria that they can work on. Why wouldn't you want a broad spectrum antibiotic to be used all the time? Yep, good. Okay, the dose needs to be individualized and appropriate to the site. So if someone's got a skin infection, you're not going to set them up on some IV antibiotics because it doesn't need to be everywhere. You just need it on the skin. You want to minimize the duration of therapy, and that's got a lot to do with some of these have insane side effects. And you want to give oral therapy where appropriate. We talked about this before. It's more convenient. So unless the person's dying of MRSA or something, don't stick them on IV antibiotics. Here's your antivirals, your antifungals. Okay, I'm just going to go through the ones that have really good mnemonics. I'm not going to go through all the drugs because it takes forever and I don't think that's a good use of this time. Okay, so rocuronium, that's one of the ANS drugs. It's a competitive antagonist of nicotinic receptors at the NMJ. So you get this extreme hyperexcitation and then it results in muscle relaxation. So it essentially paralyzes you. You remember this because you end up lying still like a rock, and also it sits in the receptor like a rock. It won't move. Okay, fluxamethonium. This is a depolarizing muscle relaxant rather than this one was a competitive antagonist. So you'll get, this one's an irreversible agonist. You'll get an overstimulation of receptors to prevent repolarization, so you'll become paralyzed. So the mnemonics that we got told was that meth is a bad drug like smoking, so remember nicotinic receptors. And meth also results in overstimulation, so like this, it overstimulates the receptors and you'll stop repolarization. And sucks because it sucks away the ability to repolarize, and it sucks by itself in surgery because you'll still feel pain. So I've just gone through 2 examples, but you can see that without knowing, okay, this is going to take too long, but you know the diagram that I drew out of all the different sympathetic versus parasympathetic nerves, if you don't know that, that's really hard to make sense of, and you're just memorizing stuff that you don't really understand. Okay, chloramphenicol. So this one, it works by irreversibly inhibiting the 50S subunit of bacterial ribosomes. The side effects are you get bone marrow suppression, which can kill the patient. So you don't want to use chloramphenicol for just anything. And you can also get grey baby syndrome because babies can't metabolize this drug. You can administer this oral or IV. The mnemonic is chlor, like a chlorine pool, and a drowned baby is grey. Sorry, it's horrible. And 50-meter pool that the baby drowned in, 50S subunit. Okay, metronidazole. This one prevents bacterial replication via DNA helix damage. So the mnemonic is metro, like trains. Train tracks look like unwound DNA. So that links with, causes DNA damage. Tracks are metal, and this links in with a really common side effect of metronidazole is the patient will get a metallic taste in their mouth and can't drink on trains. And interferes with alcohol metabolism. So patients with taking metronidazole can't drink or they'll get really upset stomachs. Okay, vancomycin. This one inhibits transglycosidase. So it's interfering with peptidoglycan synthesis. So what kind of bacteria are you using vancomycin for? Gram-positive, good. So if you got told like a case where you've got they'll tell you some sort of bacteria that the person has, they'll go, oh, Staph aureus bacteremia or something. So you've got to know your micro as well as your pharm. They won't make it so obvious as telling you, oh, it's a gram-positive bacteria. So some side effects are you can get red man syndrome if it's infused too quickly, you just turn red. And again, bone marrow suppression, you can kill the patient from this, so don't use vancomycin lightly. The administration is IV. It's really poorly absorbed from the GIT, but that's not necessarily a bad thing depending on what you're trying to treat. If the person has got some sort of GIT infection, like maybe it has to be gram-positive, so maybe something like C. diff, you can give an oral administration to just treat the site of infection, and you're not going to get so many systemic side effects because it's not actually getting absorbed. The mnemonic, so the van in vancomycin, think of it as like an ambulance van. So an ambulance is red, that's your red man syndrome. You got a loud siren, so you can get ototoxicity, so patients can go deaf after vancomycin. And imagine the van driving through a wall, that's breaking down the bacterial cell wall. Okay, gentamicin, this one has my favorite mnemonic. This one irreversibly binds to the 30S subunit of the ribosome, and it prevents protein synthesis in that way. You've broken the ribosome, basically. Your indications are they're broad spectrum for gram-negative aerobic bacteria. So learn your micro, otherwise you won't be able to answer questions even if you know the drugs. Some adverse effects, so you damage your kidneys, you can go deaf. There's increased NMJ blocker function, so they might combine some like ANS knowledge with this. And some other useful stuff. It has a really low therapeutic window. So again, don't use it lightly. Poor oral absorption. So what does that tell you about the seriousness of the condition before you need to use this? It's got to be bad, right? You don't just hook anyone up to IV. It's not convenient. And it has a really short half-life, so you got to keep administering it. So the mnemonic, gent as in gentleman, if you'd rather date someone 30 than 50, and the gentleman never leaves his lady, so that's irreversible binding. He listens to his lady, that's the ototoxicity. That one's a bit contradictory, but anyway. And breathes. That's for the aerobacteria that it targets. Oh, yeah. Okay, aciclovir. So this one's one of our antivirals. So it's a guanine analog. It's structurally exactly the same as guanine, except it's missing a hydroxyl group. So if you incorporate the aciclovir into DNA instead of guanine, the absence of the hydroxyl group prevents the attachment of additional nucleosides. So you get termination of the chain, basically. So you're preventing the DNA replication in the virus. The indications are herpes, shingles, and chickenpox. And the mnemonic is the clover at the end. You're lucky you don't have herpes. And clovers are green and guanine, green, whatever. Rifampicin. So this one inhibits bacterial RNA polymerase. So the main indication for this one is TB, and it causes bright orange everything, pee, sweat, tears. If you Google it, it looks like Gatorade. It's crazy. So the mnemonic, pissin, sounds like pissing. So you're pissing orange when you take this drug. You won't forget that, I promise. There's another mnemonic, I forgot to put it in here, for tuberculosis treatment. The word RIPE tells you all the drugs that treat TB. So rifampicin is the R, isoniazid is the I, P and E don't worry about, they're not for first year. Okay, so some practice questions. We're going to finish real early. Okay, Sam was treated for MRSA in hospital, but to the doctor's surprise, he turned quite red. What was he treated with? Good, vancomycin, red man syndrome. Oh, what are the other three for? Yep, good, isoniazid, TB. So doxy is for malaria prophylaxis, good. Can you think of another use for doxy? Acne, good. And what's chloramphenicol? Just tell me something about it. Yep, drowned baby, cool. Okay, Georgia was prescribed metronidazole. What would you advise her to avoid? What's the consensus? So I'm getting like half B, half D. The answer is D. The reason being, so yeah, B's right. C is also correct because of if you're treating someone with an antibiotic, plus you're giving them live bacteria, which if someone was infected with those bacteria for real, instead of just in a vaccine, you'd treat them with metronidazole, right? So they're cancelling each other out. And breastfeeding because it passes into breast milk. So all of the above. Is that good? Make sense? They won't ask you such obscure things like the vaccines. I just chucked it in for fun. Know the alcohol one and breastfeeding. Okay, this one's a bit obscure as well, but a patient is prescribed ritonavir. What are they being treated for, and what would you advise them to avoid? Okay, let's break this up into parts. Firstly, what are they being treated for? HIV, good. Okay, so we can get rid of A and C. The one that you're advising them to avoid is MDMA. It's just because of cytochrome P450 in the liver. They're both competing for that, so you'll get poor metabolism of the drug. That's all. Okay, this sort of question is much more representative of what you'll get in an exam. It's not as easy as just an ABCD. Okay, Amelia is a 20-year-old patient who comes to the GP complaining of vaginal itch. She recently completed an antibiotic prescription for a case of bacterial vaginosis. Which of the following drugs would you now prescribe her? Yeah, good. Fluconazole. Why? Yeah, good, exactly. So what's happened here is, so she had bacterial vaginosis, right? So she's had a bacteria infection. She's been given antibiotics, and as a consequence of taking antibiotics, she's annihilated all her normal vaginal bacterial flora, right? So it's just allowed the fungus overgrowth. So that's why we're going to give her an antifungal now, fluconazole. Okay, Vung is a 55-year-old Southeast Asian refugee with a lung infection. You prescribe her an antibiotic, advising her not to be alarmed if she experiences orange urine. It's just a side effect of the medication. What did you give her? Rifampicin, awesome. Okay, 22-year-old Ben comes to see you at the GP clinic. He's experiencing some flu-like symptoms, and you take a detailed history. You discover he's bisexual and frequently engages in unprotected sex with multiple partners. So you order a blood test. You discover he's got a blood-borne virus. Which of the following drugs would you prescribe him? Someone yell something out. F, good. So we're going with, you're thinking he has HIV, right? That's fine. HIV is not fine, but the logic behind that, good. I think there's also a case for interferon alpha, I. What's interferon alpha used to treat? Yeah, which kind of Hep? B and C, good. So because it's really unspecified that he's just got a blood-borne virus, and you can get Hep B or C from blood-borne contact through sex, not just HIV. So either I think you can make an argument for. I heard a C. Why can we not prescribe C? What is C used for? Herpes, good. Herpes is not blood-borne. That's why we're not giving C. Okay, extra points. So Ben now has a wife. She's also HIV positive. They're trying to conceive a child. What medication do you want to give Ben's wife? Just a clue, it's not on the list. Who said penicillin? Do not give antibiotics for a viral infection. Which I don't know. I've not heard of the one that you're saying. Yep. What? Sorry. Maybe. Yeah. Sure. So the drug that I was after was zidovudine. It's on the. Hang on. Where is it? Okay, zidovudine, you do need to know it. It's there. I'm not just pulling something out of nowhere. So zidovudine is specifically for preventing vertical transmission. So it's not just for like HIV in general. It's for treating, it's not on there? Okay, cool. Don't learn it. Sorry. It was when I was in first year. Okay. Emma's a 16-year-old student with moderate inflammatory acne. She's not responded to topical treatments. What are you giving her? Doxy, good. Megan's traveling to Cambodia to find herself during the uni holidays. What are you giving her? Sorry, can we louder? Doxy, good. Okay, so what are Emma and Megan now at risk of now that you've prescribed them Doxy? All of the above, good. Just an extra side note, if Emma or Megan was pregnant, you'd really not want to give them Doxy because the calcium chelation, it's not such a big deal in adults. It's more for developing young children or a fetus. They're going to have messed up teeth, messed up bones. In Emma and Megan, just yellowed teeth is not a big deal. It's not actually damaging the integrity of their teeth. How can you avoid the GI upset? What would you tell them to do when they take it standing up? Yeah, good. Okay, last one, and we'll do some cancer drugs. So 7-year-old Sally is brought to the doctor with a respiratory infection. She's coughing up sputum. She's missed 2 days of school. What are you going to prescribe her? What's the consensus? I'm hearing some B and some E. Okay, maybe I'll clarify. We're in Australia. This Sally is an Australian. Okay, so the answer is B, amoxicillin. The reason being, okay, isoniazid, what is that for treating? TB. Is Sally at risk of TB if she's in Australia? No, she's fine, right? Okay. Why aren't you going to give her A, C, or D? Yeah, so for chloramphenicol, gentamicin, and vancomycin, they're like your big guns. You save them for when the patient is dying. Sally is not dying. She's missed 2 days of school. She can just do with amoxicillin. That's your first point of call. What if we change the situation to say 7-year-old Sally is in hospital, she's dying of some pediatric cancer, and she's had surgery for her cancer, and now she's got an infection. Now, what are you going to give her? Yeah, probably, I wouldn't know the difference between A, C, and D. That comes on the microbiology, so whether it's gram-positive or gram-negative. Yeah, is that good? Vancomycin is for which one? Gram-positive or negative? Gram-positive, good. Breaking down the cell wall. Okay, I'll get out of this and go to cancer stuff. What? Karan, help me.